How long have you had that prescription? And when did you stop asking whether something better was possible? I'm not asking to challenge whether the medication works. For many men, it does. What I'm asking is something most doctors don't have time to ask. What is actually driving the problem in the first place? Because that question, the one that should have been the beginning of the conversation, is the one that gets left out. And the cost of leaving it out is something I see in my practice every single week. I'm Dr. Neraya Wolfe, urologist and pelvic surgeon. And today, we're going to have the full conversation, the one that goes past the prescription. Before anything else, I need you to anchor this entire conversation in one idea. Erectile dysfunction is not a condition. It is a symptom. And when you find the cause, the actual cause, it can be addressed. That is not semantics. That is the distinction that changes everything. A condition is something you manage. A symptom is something you trace back, to a source, to a driver, to something upstream that has been quietly building. And when you address what's actually upstream, you are no longer just managing. You are healing. The medication in the nightstand manages. Today is about understanding what's upstream. Let me start with how most of these conversations go, because the pattern is consistent enough that I can describe it precisely. A man mentions difficulty with erections. His doctor checks a few numbers, finds them within range, and writes a prescription. He's told to take it about an hour before, see how it goes, and for many men, it does go. In the moment, it works. The erection is there. The problem appears to be solved, and so the story becomes, this is my solution. This is what I need. This is how it is now. But here is what that conversation almost never includes, and what I believe every man deserves to understand. The medications most commonly prescribed for erectile dysfunction, the ones that work by enhancing nitric oxide and increasing blood flow to the erectile tissue, are not treating the underlying process that created the problem. They are working around it, brilliantly, in many cases, effectively, for many men. But they are not addressing what created the symptom in the first place. And when we treat a symptom without understanding its cause, we don't actually get better. We stay managed, we stay dependent, we stay in a holding pattern that never quite resolves, and that, over time, quietly becomes the ceiling. I want to be very clear. I am not here to take medication away from anyone. For men with significant vascular disease, for men who have undergone prostate surgery, for men whose physiology genuinely requires pharmaceutical support, medication is an essential and appropriate part of their care. What I am saying is that medication should not be the first and only conversation. For a great many men, particularly those whose dysfunction is driven primarily by lifestyle factors, hormonal imbalance, pelvic floor weakness, psychological patterns, or metabolic disruption, there is a meaningful path toward restoration that nobody ever explained to them. That is the lie. Not that pills don't work, they do. The lie is that pills are the whole answer. For far too many men, they are simply a very convenient place to stop asking questions. To understand why this matters so deeply, I need to walk you through what an erection actually requires. Because when you understand the full biology, you immediately see how many different systems are involved, and how many of them can be influenced. An erection is not a plumbing event. It is a whole-body coordination. For it to happen reliably, several systems need to be working simultaneously, and when even one of them falters, the entire process becomes less reliable, sometimes unreliable, sometimes absent altogether. The first system is vascular. Blood flow into the erectile tissue depends on healthy, elastic blood vessels that can dilate efficiently in response to arousal. The arteries that supply the erectile tissue are among the smallest in the entire body. Think of your circulatory system as a network of pipes. The arteries feeding the heart are the main trunk lines, wide and resilient, built to handle sustained high pressure. The arteries feeding the penis are the narrowest branches at the far end, and the narrowest pipes show the effects of any systemic problem. Buildup, stiffening, loss of elasticity, years before the larger vessels do. Here is the analogy I want you to hold. Think of blood vessels in a healthy body like new rubber hoses, supple, responsive, flexible under pressure. They deliver full flow where it needs to go. Now imagine those same hoses left outside for 20 years. Sun, heat, the elements, no maintenance. They harden, they narrow at the bends, they crack under pressure. The flow that arrives at the end is a fraction of what the source is sending. Not because the supply changed, because the vessel lost its responsiveness. That is what happens to blood vessels under chronic inflammation, elevated blood sugar, and years of a pro-inflammatory lifestyle. and those narrow penile arteries show the damage first, often years before the coronary arteries show any clinical sign. Which is why, when a man in his 40s or 50s mentions erectile changes to me, I am thinking about his cardiovascular system. This is not a bedroom problem in isolation. This is an early cardiovascular signal, and catching it as such changes everything. The second system is hormonal. Testosterone plays a central role not just in desire, but in the neurological and vascular mechanisms that produce and sustain an erection. When it is significantly low, and this is far more common than most men realize, often missed because total testosterone is measured without free testosterone, erection quality can decline even when everything else appears normal. The third system is neurological. An erection requires precise communication between your brain, your spinal cord, and the nerves of the pelvic region. Conditions like diabetes, certain medications, and chronic psychological stress can disrupt this signal chain, so that even when blood flow is intact, the instruction to dilate never arrives cleanly. The fourth system is the pelvic floor. Two specific muscles, the ischiocavernosus and the bulbospongiosus, wrap around the root of the penis and perform a critical function. They compress the veins that would otherwise allow blood to drain from the erectile tissue, sealing in the pressure that creates firmness. Think of squeezing a garden hose at the end. The pressure upstream builds immediately. That is what a trained pelvic floor does to the blood inside an erection. When these muscles weaken, with age, with prolonged sitting, with a lifetime of never being trained, the seal weakens. Blood fills the tissue as it should, then escapes before it should, and the erection softens. The fifth system is psychological. The nervous system state required for an erection is parasympathetic dominance, your body's calm, present, connected mode. Chronic stress and performance anxiety keep the sympathetic system activated, fight or flight, which is the direct physiological opposite of what erections require. One difficult experience in the bedroom creates anticipatory fear for the next. That fear activates the sympathetic system before intimacy even begins, which makes another difficult experience more likely, which deepens the fear. The cycle tightens on its own, completely independent of the original physical cause. Now, every single one of these 5 systems can be influenced, some through lifestyle, some through targeted training, some through appropriate medical intervention, some through a combination. The medication that is most commonly prescribed primarily addresses one mechanism, blood flow, through nitric oxide enhancement. For a man whose primary issue is mild to moderate vascular compromise, it works beautifully. But for the man whose primary driver is low testosterone, a weakened pelvic floor, chronic stress, or metabolic disruption, the medication is doing something, just not the thing that actually needs to happen. Before I walk you through what to actually do about each of these drivers, if the kind of honest, clinical education we've been building today is what you've been looking for, I'd ask you to subscribe to this channel. Every week we cover the topics most men never receive real answers to in a standard appointment. That is exactly why this channel exists. Now, let's talk about what can actually change. Now, before you say, I've already tried exercising more and eating better and nothing made a real difference, let me stop you right there, because what I'm about to give you is not a general wellness lecture. It is a specific, mechanism-driven set of interventions, each one targeting a precise biological driver of the problem we just mapped out. When you do these things, understanding why they work, the results are different. Let's go through them. Driver 1, vascular health. The most powerful vascular intervention is consistent aerobic exercise, and I want to say this clearly, because it is often delivered as a vague lifestyle suggestion when it is actually a clinical recommendation with robust evidence behind it. Regular cardiovascular challenge, brisk walking, cycling, swimming, rowing, 30 to 45 minutes, most days of the week, is among the most effective stimuli for endothelial recovery available outside pharmaceutical intervention. It improves nitric oxide production. It promotes angiogenesis, the development of new small blood vessels. It reduces systemic inflammation and lowers blood pressure. The research is consistent. Men in their 50s and 60s who begin a structured aerobic program show measurable improvements in vascular markers and in erectile function specifically. Not as a side effect, as a primary outcome. Dietary change matters here as well, specifically reducing the chronic inflammatory load. Ultra-processed foods, refined sugars, excess alcohol, trans fats, and adding leafy greens, quality, fats from olive oil and fatty fish, and foods that support nitrate production. The Mediterranean. Dietary pattern has among the strongest evidence bases in men's sexual and cardiovascular health. This is not a soft suggestion, it is a real biological lever. Smoking cessation may be the single most impactful vascular change a man can make. The measurable improvement in erectile function begins within weeks of stopping. Driver 2. Hormonal balance. If low testosterone is a contributing factor, and the only way to know is a proper blood panel, then addressing it produces results that medication alone cannot replicate, because testosterone does not just affect desire. It affects the neural pathways, the vascular responsiveness, the psychological dimension of arousal, the entire environment in which erections happen. A man relying on erectile dysfunction medication while carrying undiagnosed low testosterone is trying to improve the output of a system whose fundamental fuel is depleted. A complete evaluation requires total testosterone, free testosterone, and sex hormone-binding globulin, SHBG. Free testosterone is what your tissues can actually use. It can be critically low, while total testosterone appears completely normal on paper. That gap is one of the most common things I find in men who have been told their labs are fine and sent away without answers. If you haven't had this panel and you are experiencing erectile changes after 40, please make that conversation happen. Driver 3. Neurological function and metabolic health. Diabetes and prediabetes are among the most significant contributors to erectile dysfunction I see clinically. The neuropathy that develops with chronically elevated blood sugar directly damages the nerves responsible for the erectile response, and managing blood glucose through dietary change, exercise, weight reduction, and where appropriate, medication can meaningfully improve or even reverse this damage when caught early. Addressing insulin resistance is not secondary care for ED. In many men, it is primary care. Driver 4. Pelvic floor strength. The research here is genuinely compelling, and this driver receives less clinical attention than any other relative to how significant it is. A landmark study published in the British Journal of General Practice found that men who completed a structured pelvic floor exercise program showed significant improvement in erectile function, and a substantial percentage regained normal function entirely. Not with medication, not with surgery, with targeted muscle training performed consistently. The ischiocavernosus and bulbospongiosus are trainable muscles. They respond to exercise the way any muscle does. Unlike almost every other muscle group in the body, they receive no passive stimulation from ordinary daily activity. They weaken in silence, without any pain signal, without any obvious announcement. The exercises that rebuild them take minutes per day, require no equipment, and produce changes that are real, measurable, and lasting. If you haven't watched my video specifically on performing pelvic floor exercises correctly, I want to encourage you to do that. The mechanics of why most men don't do them correctly is fully explained there, and the difference matters. Driver 5. Psychological and nervous system regulation. The performance anxiety cycle is one of the most self-reinforcing patterns in men's health. One difficult experience creates anticipatory fear. The fear activates the sympathetic nervous system before the next encounter even begins. That physiological tension makes another difficult experience more likely. The cycle tightens, and medication, while it can interrupt the cycle by providing a successful experience and breaking the anxiety loop, does not touch the underlying story a man tells himself about what his body means. Cognitive behavioral therapy and sex therapy have genuine, evidence-backed effectiveness for exactly this pattern. Mindfulness and stress regulation are not soft add-ons. They are physiological interventions with measurable effects on cortisol, on sympathetic activation, and on the hormonal environment in which erections occur. Treating them with the same seriousness as any other clinical recommendation is precisely what the evidence supports. If you are currently relying on medication for erectile function, I am not asking you to stop. What I'm asking you to do is have a more complete conversation. A thorough evaluation of erectile dysfunction begins with your story. Not a symptom checklist, but a real conversation. When did changes start? How have they progressed? What do mornings look like in terms of spontaneous erections? How is your sleep? What is your stress level? What medications are you on? Do you smoke? How much do you drink? Is there a family history of diabetes, heart disease, or high blood pressure? Every one of these questions is connected to the biology we've just walked through. Everyone matters. Laboratory testing should include, at minimum, a comprehensive metabolic panel, fasting blood glucose and HbA1c to screen for diabetes and prediabetes, A full lipid panel, blood pressure measured as a pattern over time, not just a single clinical reading, and a complete hormone panel, total testosterone, free testosterone, SHBG, LH, and prolactin. A proper evaluation should include some assessment of the pelvic floor, either through clinical examination or referral to a pelvic floor physical therapist, and it should include an honest conversation about lifestyle, not a cursory recommendation to exercise more, but an acknowledgement that these are genuine evidence-based treatments, not afterthoughts, primary interventions. If you have never had this kind of evaluation, if the conversation ended at the prescription, you are allowed to go back and ask for it. You are allowed to say, I want to understand what is actually driving this. I want to know what I can change. I want the complete picture, some of the most important words you can bring to a medical appointment. What is causing this, and what can I actually do about it? A urologist who specializes in men's sexual health will welcome those questions. If they don't, find someone who does. I want to be genuinely honest about outcomes, because I believe honesty is more respectful than hope that isn't warranted. For some men, particularly those with significant long-standing vascular disease, or those who have undergone prostate or pelvic surgery, the pathway back to fully spontaneous, reliable erections without any assistance is genuinely limited. The damage to blood vessels or nerves in those cases may be irreversible. For those men, medication is not a crutch. It is appropriate, compassionate, effective care. And there are further options, vacuum devices, penile injection therapy, implant surgery, that are highly effective and deserve a proper, complete conversation with a urologist who specializes in sexual medicine. There is no dead end here, but honesty requires naming that not every pathway leads to the same place. That population, however, is not the majority of the men watching this. The majority of men relying on medication for erections after 40 are doing so not because their body is irreparably damaged, but because the underlying contributors to their dysfunction have never been fully identified or addressed. The testosterone that was never tested, the pelvic floor that was never trained, the blood sugar that crept up without anyone noticing, the stress that became chronic without anyone naming it, the anxiety loop that started with one difficult night and was never interrupted. For those men, and there are many of them, real change is possible. Not guaranteed, not easy, not instant, but possible in ways that go far beyond what a pill can offer. I've watched it happen for thousands of men. Men who came in convinced that the pill was the ceiling, who left with a complete picture of what was actually driving the problem, addressed it directly, and found over months of consistent work that the ceiling had moved, that what they thought was permanent had turned out to be fixable, that their body remembered what it had been quietly waiting to be given the conditions to do. Before you close this video, I want to ask you something. What have you lost? Not to shame you, but honestly, what has the pill in the nightstand life cost you? In the spontaneity that used to just be part of who you were, in how present and confident you've been able to be, in the intimacy that became something you have to prepare for instead of something you simply live. In the quiet space between you and the people who matter most to you? Because here is what I know. After years of sitting across from men who carried exactly this quietly, often for far longer than they should have, the ones who find their way back are not the ones with perfect genetics or easy circumstances. They are the ones who decided that understanding what was actually happening in their body was worth more than the comfort of not having to examine it, who stopped accepting the ceiling, who walked into a room and said, I want the complete conversation. Men are remarkably good at managing, at adapting, at carrying things quietly and getting on with the day. And there is something genuinely admirable in that. But managing is not the same as healing. Adapting is not the same as understanding. And getting on with the day is not the same as living fully inside it. The pill in the nightstand is not the problem. The problem is when it becomes the ceiling, when it becomes the limit of the conversation, the end of the investigation, the point at which a man stops asking whether something better is possible. You are worth more than a ceiling. Your body has remarkable capacity to respond when it is finally given what it needs. One step, taken genuinely, leads to another, and another. And at some point, you look back and realize that the man who quietly reached for that prescription every time, and the man who understands his own body and takes care of it from the inside out, those are two very different lives. You deserve the second one. If today gave you something real, if this is the honest, complete clinical conversation you've been looking for, please subscribe to this channel. Every week, we cover exactly these topics, the ones that don't fit in a 10-minute appointment, but that every man deserves to fully understand. I've also linked a video above that takes the next step from exactly where we left off today. Take care of yourself, because you are absolutely worth it.